يلا. العرض واضح لكم؟
Yeah, it's very clear.
إيه. السلام عليكم، أنا إبراهيم النفيسة، طبيب امتياز interested in pediatrics. بقدم محاضرة عن ال RDS with emphasis on the European recommendation on the management of RDS. Definition كلكم عارفين إنه formally called hyaline membrane disease, والpathophysiology is simple, surfactant deficiency caused by the immature type 2 pneumocyte. بس المشكلة في تعريف السرفاكتنت. What is surfactant؟ أول شيء عشان نفهم السرفاكتنت هو لو عندنا alveolus at inspiration and every alveolus has a thin layer of water inside. At inflation, the thin layer is separated and not condensed. But at expiration, the thin layer of water become more condensed and more attractive to each other. لأن الwater molecules tend to pull each other by intermolecular forces لأن عندها high cohesive force because of the strong hydrogen bonds. This will create a high surface tension and prevent the alveoli from inflation. But with the addition of surfactant, surfactant act like a wall between the water molecules on the surface. So it separates the water molecule and prevent the high surface tension. This will allow the alveoli to be inflated easily. This is a simple practical example illustrating the surface tension on the cylindrical piece of plastic. This is a cylindrical piece of plastic. When you add a liquid inside, as shown here, it collapsed. Laplace law is pressure equal to 2 times the surface tension divided by the radius. Laplace law describes pressure and surface tension in a spherical structure. But here comes a question, are alveoli spheric or not? Actually, or interestingly, alveoli are not spheric. They are prismatic or polygonal in shape, but there is some areas of the alveoli that are curved. So Laplace law cannot be applied on every area of the alveoli. Clinical manifestation, it is respiratory distress, tachypnea, nasal flaring, expiratory grunting. Grunting occur as a reflex to give an end expiratory pressure. It occurs by partial closure of the glottis during expiration to prevent end expiratory alveolar collapse. Also retraction, cyanosis, and decreased breath sounds. Diagnosis by the clinical manifestation and by increase in the oxygen requirement, plus the characteristic chest radiograph. But be careful, the radiographic appearance of the characteristic ground glass with air bronchogram are rarely seen today due to early surfactant therapy and early CPAP. Now we come to the management. For every disease, first thing to think of is prevention, how to prevent the disease. To prevent RDS, the most common cause of RDS is preterm delivery. So if we prevent preterm delivery, we can decrease RDS. Suggested approach is to divide it before pregnancy, then at pregnancy. Before pregnancy, what we can do, we can increase the interval between pregnancy to at least 1 year, maintain healthy lifestyle, smoking cessation, regular prenatal care, prevention reduction of multifetal gestation. But the most important here, which is not to prevent preterm delivery, but to facilitate the management of RDS, is the risk prediction of preterm delivery and the need for appropriate maternal transfer to a perinatal center. At pregnancy, we can divide it by the weeks of gestation. In the first trimester, we can do urine culture and give antibiotic for asymptomatic bacteriuria to decrease preterm delivery. We can give progesterone supplementation for any woman with a previous history of preterm delivery. We can secrete on 18 to 24 weeks, we can secrete for short cervix and apply cerclage if indicated. At 23 to 31, we can give magnesium sulfate, but this one not for the prevention of preterm delivery. It is just for the decreased risk of cerebral palsy. It is recommended by the European guidelines. The most important thing is at 23 to 33 weeks of gestation, if there is an attack of preterm delivery, it is strongly recommended to give a single course of prenatal corticosteroid and tocolytic therapy. Tocolytic therapy not to prevent the preterm delivery, it is just to delay the delivery so the course is completed and there is time to transfer to a perinatal center. This is the European guidelines on the management of RDS. For every recommendation, they have a grade. The grades have a letter and a number. The letter is describe the quality of the evidence. A for high quality, B for moderate quality, C for low quality, D for very low quality. And the numbers for the strength of recommendation. 1 is for strong recommendation, 2 for weak recommendation. For the prenatal care, they recommend mother at risk of preterm birth should be transferred to a perinatal center. 2 is the antenatal corticosteroid. Ideally, it should be before 34 weeks and ideally at least 24 hours before birth. 3 is considering repeating the course if it was before 32 weeks and there is 1 or 2 weeks apart from the first dose. 4 is the magnesium sulfate to decrease the risk of cerebral palsy. 5 in women with symptom preterm labor, cervical length and fibronectin measurements should be considered to prevent unnecessary use of tocolytic drugs or antenatal steroid, because these drugs are not free of adverse effect. We should confirm the preterm labor before giving them. 6, clinicians should consider short-term use of tocolytic drug in very preterm pregnancy to allow completion course of corticosteroid and or in utero transfer to a perinatal center. It is not, the tocolytic drugs not used to prevent preterm delivery. It's just used to complete the course of corticosteroid and to give time to transfer to a perinatal center. Now we finished from the prevention, we come to the delivery room stabilization. If we have a preterm baby at risk of RDS, what can we do? First, we can delay the cord clamping for at least 60 seconds. This can give the baby for up to 80 milliliter of blood. It's like a blood transfusion. And if you cannot delay the cord clamping, you can do cord milking as an alternative. You must give plastic bags or occlusive wrapping for a preterm baby less than 28 weeks of gestation, because preterm babies have premature skin, and this skin allow allow the heat to escape from the body and cause hypothermia. Hypothermia increase mortality in preterm babies. And if the baby is spontaneously breathing, stabilize with CPAP. Of course, oxygen. If the baby is more immature, he needs more oxygen. So less than 28 weeks, you can give up to 30% oxygen. Our goal is to achieve oxygen saturation of 8%, 80%, and the heart rate of more than 100 within 5 minutes. What about prophylactic surfactant? Prophylactic surfactant was given for the smallest baby, but now with the use of antenatal steroids and the CPAP, they found that best if surfactant is reserved for infants showing clinical signs of RDS. يعني rescue surfactant. Prophylactic surfactant is not recommended. هذه الأوروبيان guidelines من ناحية الدليفري روم stabilization. واحد عندنا delay cord clamping. It is simple and strongly recommendation. As you can see, A1. A is for high quality and 1 is strongly recommended. 2, in spontaneously breathing baby, stabilize with CPAP. The emphasis that do not use sustained inflammation, as there is no long-term benefit and it can harm the premature lung. If CPAP is not effective, you can give gentle positive pressure lung inflation with 20 to 25 centimeter water PEEP. 3, oxygen for resuscitation should be controlled. Use a blender. Use an initial of oxygen fracture of 0.3 for babies less than 28. The more premature, the more oxygen requirement they need. Also, the oxygen fraction should be adjusted up or down, guided by the pulse oximetry. As a rough guide, it should be 60% to 65% at 1 minute, then increased by 5% for every 1 minute. Until you reach at 5 minutes, it should be 80 and above. At 10 minutes, it should be 90 and 95%. 4, for infant less than 32 weeks of gestation, this is the oxygen goal. It should be 80%. 5, intubation should be reserved for babies not responding to positive pressure ventilation. We should avoid intubation as possible. 6, babies who require intubation for stabilization should be given surfactant. This is logic because we try our best not to give surfactant because of the risk of intubation. But here he is already intubated. 7 is the plastic bag and occlusive wrapping for less than 28 weeks of gestation, because hypothermia can increase mortality. It is strongly recommended with high quality. Now we finished from the delivery room stabilization. We come to the surfactant. What is surfactant? It's a contraction of surface active agent. It is any amphiphilic phospholipid compound that lowers the surface tension between two phases, gas or water. There are many examples of surfactant. As a simple example, soap is a surfactant, shampoo is a surfactant, detergent is a surfactant, any emulsifier is a surfactant. In the human body, there are 2 surfactants. Bile acid is a surfactant and the pulmonary surfactant. This illustrates the types of surfactant and the shapes that can be made. But Pulmonary surfactant, we have bovine or porcine or synthetic. Bovine means it came from cows or calves. Porcine from pigs and synthetic from the laboratory. Bovine, we have piractant or survanta, also calfactant or infrasource. Porcine, we have boractant alpha or corosurf. This is the most widely used, and it is recommended by the European guidelines. There are many types of synthetic surfactant, and they are out of the scope of this lecture. When to use rescue surfactant, there is two indications. If intubation is required for stabilization in the delivery room, or if high oxygen concentration is used with a CPAP of at least 6 centimeter water to achieve more than 89% of saturation. What defines high oxygen concentration? Some say it's 80%, 40%, or 30%. But the European guidelines agreed on 30%. Administration, there are many types of administration. The most widely used is tracheal intubation, but the disadvantage is invasive. It is invasive. Second is in-shore technique. It is intubation surfactant extubation. It avoids the invasiveness of intubation, but there is a concern that arises. Should we use sedation or not? Third is the specialized catheter, MIST or LISA. MIST is minimally invasive surfactant therapy. LISA is a less invasive surfactant administration. MIST is, they use a small vascular catheter guided by McGill forceps. LISA is, they use a specialized surfactant catheter guided by laryngoscopy. The disadvantage of this technique is they require skills and there is no airway control if an obstructed airway happened. بعدين عندنا اللارنجيل ماسك airway non-invasive بس مشكلته إنه big in size. يستخدم فقط لل late preterm infants. بعدين next عندنا nebulization. Actually, the nebulization was the first technique to be used, but at that time they didn't have a good surfactant that withstand the power of nebulization. السرفاكتنت كان يخرب يتكسر. بس مع synthetic surfactant they may reintroduce the nebulization. And it is the truly non-invasive method. Next is the pharyngeal deposition. Many preterm infants are managed by CPAP without surfactant, avoiding the invasive of intubation. But a new non-invasive method are promising, and trials showed early use of surfactant with CPAP can improve outcomes. What's the European guidelines on the surfactant? One is babies with RDS should be given an animal-derived surfactant because it has been shown that the animal-derived surfactant is superior in clinical trials to synthetic preparation. But they did not compare with a new type of surfactant with the addition of protein B and C. They compared with the old versions of the synthetic. Two, a policy of early rescue surfactant should be standard, but there are occasions when surfactant should be given in the deliveries, such as when intubation is needed for stabilization. They all agreed that surfactant should be used as a standard, but they are not sure on the best standard policy. 3 is the policy. 3, babies with RDS should be given rescue surfactant early in the course of the disease. And the suggested protocol would be to treat babies who are worsening when fractional oxygen is more than 0.3. But they did not agree because, as you can see here, it is good quality of evidence, but weak recommendation. For Boractant alpha at an initial dose of 200 milligram per kg is better than 100 milligram per kg of Boractant alpha or 100 milligram of Piractant for rescue therapy. They found that a bigger initial dose is better than smaller dose. 5, LISA is the preferred method. We want to avoid intubation as possible. 6, a second and occasionally a third dose of surfactant should be given if there is ongoing evidence of RDS. But with the use of bigger doses, we can manage without the second and third dose. Now we go to the oxygen. Oxygen is a drug. It has an indication and has side effect. We should weigh the risk and benefit. Oxygen causes pulmonary vascular dilatation and improve gas exchange, but on the other hand, it causes retinal vascular constriction and promote new vascularization and can cause retinopathy of prematurity. The guidelines on oxygen is as follows. In preterm babies receiving oxygen, the saturation should be between 90 to 94%. But one may ask, why not lower? Studies showed lower target range of oxygen of 85 to 89% as compared with a higher range, 91 to 95%, increases mortality and does not affect the rate of PPD, blindness, or neurodevelopmental impairment. Alarm limit should be set to 89 and 95%. This is logic. Now we come to the non-invasive respiratory support. There are many types of support and there are many types of interfaces. CPAP, which is the most recommended, it acts by increasing the functional reserve capacity by preventing losing of volume of the lung. It applies pressure, which increases lung capacity, which can increase lung compliance and reduce airway resistance. There are 2 types of CPAP. There is a constant flow and a variable flow. The constant flow have also 2 types, a flow driver or bubbler system. The flow driver is the conventional CPAP. The bubbler system is similar to the flow driver, but it is different by it can generate small fluctuation on the pressure. So the pressure is not always constant. It is easy to use and it is cheap. But the clinical advantage needs more studies. Bi-level positive airway pressure, they found that there is no evidence that BiPAP have any advantage over CPAP. Nasal intermittent positive pressure ventilation, also they didn't find any evidence to recommend NIB as a primary mode of respiratory support. But when they used synchronized NIB, they found there may be an advantage. High flow nasal cannula, High flow nasal cannula work by flushing the nasopharyngeal dead space, and you must leave a leak around the nostril, so the nasal bronch should be smaller than the nostrils. And there are more of types of support. We will see what the guidelines will recommend. Interfaces, there is also many: nasal bronchs or mask or pharyngeal, short pharyngeal tubes or helmet mask. The European recommendation, CPAP should be started from birth in all babies of at risk of RDS. Also, CPAP is recommended as the first line therapy by the WHO. 2, the system delivering CPAP is of little importance, so we can use any system of CPAP, babbular CPAP or any other. However, the interface should be short binasal bronchs or a mask with a starting pressure of about 6 to 8 centimeter water. 3, positive end expiratory pressure can then be individualized depending on clinical condition, oxygenation, and perfusion. Some say it can depend on the chest rise. CPAP with early rescue surfactant is considered optimal management for babies with RDS. We must give a rescue surfactant as early as possible when indicated, but not as a prophylactic. 5 is a synchronized NIV, if delivered through a ventilator rather than BiPAP device, can reduce extubation failure. But they don't have any advantage, long-term advantage. 6, during weaning, high flow nasal cannula can be used as alternative to CPAP for some babies with the advantage of less nasal trauma. As we have said before, high flow nasal cannula uses catheters that are specifically designed not to occlude the nostril, so it will not cause any nasal trauma. Unfortunately, many infants need or require mechanical ventilation. It is harmful to immature lungs and should be avoided if possible. But it is the mainstay of therapy for infants with RDS in whom have apnea or hypoxemia with respiratory acidosis. There are too many modes of modes and ventilator settings. For the sake of simplicity, we have two types of mode: pressure control mode and volume control mode. The European guidelines recommend a volume control mode. So we can change the pressure and wean for a less pressure, because the pressure is the main cause of lung injury. While using the mechanical ventilation, they suggested to use a budesonide inhaler to decrease the inflammation and the risk of BPD. Also, they recommend using permissive hypercarbia because studies have shown that it is safe and there is no long-term risk. Also, if you are extubating the baby, you can use systemic corticosteroid, but if used early, it may cause a neurodevelopmental problems. Caffeine should be prescribed for any baby at risk of mechanical ventilation or he is on mechanical ventilation. Analgesia and sedation, there is controversy on this topic. This is the recommendation. 1, after stabilization, mechanical ventilation. Yeah, here again, we should avoid intubation as possible. Then duration of mechanical ventilation should be minimized. try to extubate as soon as possible, as soon as satisfactory gas exchange is achieved. 3, the primary choice of ventilation mode is at discretion of the clinical team. So there is a freedom in the choice of the ventilation mode. However, if conventional mechanical ventilation is used, targeted tidal volume ventilation should be employed, which is the volume control mode. 4, when weaning from mechanical ventilation, it is reasonable to relate a modest degree of hypercarbia, provided that the pH remain above 7.22. Because as the studies showed that permissive hypercapnia is safe. Caffeine should be used to facilitate weaning from mechanical ventilation. Early caffeine should be considered for baby at high risk of need of mechanical ventilation. This is the use of prophylactic caffeine. It is not recommended unless the baby is at high risk of mechanical ventilation. A short tapering course of low dose or very low dexamethasone should be considered to facilitate extubation. Inhaled budesonide for any baby at risk of BPD. Here, the opioid should be used selectively when indicated by clinical judgment and evaluation of pain indicator. As we can see, although there is only very low quality evidence, they strongly recommend it. Because interestingly, some found that invasive painful procedure can affect regular head circumference growth and short-term cognitive score. Last one, the routine use of morphine or midazolam infusion in ventilated preterm infant is not recommended. Now we come to the monitoring and supportive care. What can we do? We can apply continuous pulse oximeter monitoring, ECG monitoring, but it's not necessary. Cerebral oximeter, but it's not necessary. And studies showed no clinical no advantage in clinical outcomes. Transcutaneous oxygen or CO2 monitoring. But the disadvantage of this one is the need for daily recalibration and relocation to different skin sites because it can cause skin irritation and skin burn. CBC and electrolyte, it is crucial. Umbilical cord, umbilical artery canalization if there is a need for frequent gas, arterial gas. And also we must maintain the body temperature between 36.5 to 37.5 because as we have said before, hypothermia increases mortality. This is the European guideline. Core temperature should be maintained, as we have said. Avoid hypothermia at delivery and after admission. Most babies started on intravenous fluid, 7 to 8 milliliter per kg per day in a humidified incubator. Although some very immature babies may need more. The more immature, the more water loss through the skin. So they need more IV fluid. Fluid must be tolerated individually according to serum sodium and urine output and weight. Parental nutrition should be started from birth. Amino acid 1 to 2 gram per kg per day should be started from day 1 and quickly build up to 2.5 to 3.5 gram per kilogram per day. Lipid should be started from day 1 and build up to a maximum of 4 gram per kilogram per day if tolerated. Enteral feeding with the mother milk should be started from the first day if the baby is hemodynamically stable. I want to add that the WHO recommend kangaroo care for any premature baby. The European guidelines on the blood pressure and perfusion treatment of hypertension is recommended when it is conferred by evidence of poor tissue perfusion, such as oliguria, acidosis, and poor capillary return, rather than purely on numerical values, because we cannot define hypotension by numerical values. And the studies have shown that treating hypotension by numerical values is not doesn't have any advantage. Hypotension is associated with adverse long-term outcomes, so it must be treated. Two, if a decision made is to admit therapeutic closure of the PDA, then indomethacin or ibuprofen or paracetamol can be used. Paracetamol has less toxic effect on the kidneys, but indomethacin and ibuprofen are associated with less failure rate. Hemoglobin concentration should be maintained with an acceptable limit. More restrictive blood transfusion has similar outcome to liberal blood transfusion, but they found that one study showed long-term better cognitive outcome with the use of liberal use of blood transfusion. So hemoglobin threshold for infant with severe cardiopulmonary disease is 12 with a hematocrit of 36%, 11 gram per deciliter and hematocrit of 30% for those who are oxygen dependent, and 7 gram per deciliter and hematocrit 25% for stable infant beyond 2 weeks of age. Last recommendation, they recommend that surfactant can be used for RDS complicated by congenital pneumonia, because here the pathophysiology is similar to surfactant deficiency, but it is surfactant inactivation. Also, surfactant therapy can be used in pulmonary hemorrhage, same pathophysiology, surfactant inactivation. Use of nitric oxide in preterm baby should be used with caution and limited to these in clinical studies or as a therapeutic trial when there is severe documented pulmonary hypertension. So it is not recommended to use nitric oxide. Thank you so much. Any questions? هذا الريفرنس.
شكرا جزيلا إبراهيم، صراحة يعني محاضرة أكثر من رائعة، وخصوصا يعني إنه it's prepared in very short time. يعني we agreed to present it last week and you was able to prepare it in very short time, and it's very good يعني quality regarding the slides, knowledge, presentation. صراحة يعني رائعة جدا، الله يجزاك خير، محاضرة أكثر من رائعة حقيقة. I don't know if anybody has a question for Ibrahim regarding the lecture.
I really would like to thank Dr. Ibrahim for
the talk. Hello.
Hello, Helen. شكرا.